Hey everyone, and welcome to The Explainer. If you're a pharmacist, you know this better than anyone. Patients with low back pain are a constant in our daily practice. Today, we're going to break down the latest guidelines, which are really changing how we should be thinking about this super common condition. Let's get right into it.
First things first, let's just wrap our heads around how huge this problem actually is.
This isn't a problem that just vanishes. We used to think, hey, 90% of people get better in a few months, right? Well, it turns out the newer data tells a pretty different story. The big takeaway here is that for most people, this is something that sticks around. It's chronic, it's recurring, and that makes our role in managing it long-term so critical.
All right, so here's how we're going to tackle this today, basically like a clinical workflow. We'll start with the big picture, the global burden. Then we'll jump into patient assessment. After that, we hit the most important part, non-pharmacologic therapy first. Then we'll review the meds and wrap it all up with a solid plan for counseling and monitoring.
Okay, Section 1, a global health burden. Really understanding the scale of this problem is key to seeing why the guidelines had to change so dramatically.
Let me just say this plainly. Low back pain is the #1 cause of disability on the entire planet. That's huge. I mean, look at this. Up to 80% of us are going to deal with this at some point. And yeah, people might feel better in those first 6 weeks, but what happens next? Relapses. They're super common. And for up to 10% of people, this becomes a chronic, life-altering problem. These are the folks walking into our pharmacies every day.
All right, so that brings us to our part of the puzzle. Section 2 is all about assessing the patient. And honestly, this is the first, most critical step we take. Before we even think about a single medication, we have to play detective and triage the situation. This is where our clinical skills really shine.
Think of it like a 3-step checklist. First up, we're on the lookout for red flags. These are the big, scary things that mean stop, refer immediately. Next, we're identifying yellow flags. These are more like warning signs that tell us this person might be headed for chronic pain. And finally, we categorize the pain, because that's going to shape everything that comes next.
Okay, let's be super clear about red flags. These are absolute deal breakers. Non-negotiable. If a patient mentions symptoms of cauda equina syndrome, or they're getting weaker, or they've lost a bunch of weight for no reason, or they have a fever, these are not our problems to solve. These are giant flashing stop signs. Our job is to recognize them and get that patient to a doctor ASAP.
Now, yellow flags are a bit different. They're not as alarming, but they are just as important. These are the clues in a patient's life that tell us they're at high risk for this becoming a long-term battle. We're talking about things like depression, anxiety, maybe they can barely function when the pain first hits, or they're dealing with a really stressful job. When we spot these, it's a signal that this patient is going to need more than just a pill.
Okay, so after we've done our assessment, we arrive at the single biggest shift in how we manage low back pain. And here it is. Non-pharmacologic therapy comes first. Period. This is the new foundation of everything we do.
So what are we even talking about here? Well, check out this list of options. If the pain is acute, it's often about simple stuff, reassuring them, encouraging them to keep moving gently, maybe using a heat pack. But for that persistent, chronic pain, the toolbox gets bigger. We're talking about structured exercise, things like yoga or Tai Chi. The main point is, our conversation has to start with these options, not with what's in a bottle.
So let's just put this side by side, because this is a huge practice change. The old way, a patient comes in, we say, try some acetaminophen. Well, that's completely out the window. In fact, acetaminophen isn't even recommended anymore because, frankly, it just doesn't work well for back pain. The new rule is simple. Step 1 is always non-drug therapy. Only if that's not cutting it, then can we talk about medication, and our first choice for that is going to be an NSAID.
All right, so let's move on to the meds. Section 4, reviewing pharmacologic options. But I want you to keep one word in mind here, adjuncts. These are not the main event. They are tools to support the non-drug therapies, and we have to use them carefully.
So when we do reach for a medication, the guidelines are very specific. NSAIDs are the one and only class recommended for first-line pharmacologic therapy. And we're not looking for a magic bullet. The goal is a modest but meaningful improvement in their pain and their ability to function.
And here are the two heavy hitters, ibuprofen and naproxen. We all know these inside and out, but it's always good for a quick refresher. For ibuprofen, we're talking 200 to 400 milligrams every 6 to 8 hours. For naproxen sodium, it's 220 milligrams, maybe once or twice a day. And the golden rule, as always, is lowest effective dose for the shortest possible time.
But of course, NSAIDs are not Tic Tacs. They come with real risks, and our counseling has to be on point. I think of it as the big 4 risks. You've got GI risk, that's the classic take with food conversation. You've got cardiovascular risk,
Then there's renal risk, where we have to be super careful with our older patients. And finally, don't forget the drug interactions. Think warfarin, blood pressure meds, SSRIs, the list goes on.
Okay, so what about muscle relaxants? Everybody asks for them, right? Well, this is where the guidelines really pump the brakes. They tell us to be extremely cautious. Why? Because the evidence that they actually work is kind of murky. And their side effects? Well, those are definitely not murky.
I mean, just look at the fine print for drugs like cyclobenzaprine or baclofen. The notes say it all: short-term use only. Don't use in the elderly. That's because these drugs are basically cousins of tricyclic antidepressants, and they bring all of that baggage with them, especially the CNS side effects.
So here's the bottom line on muscle relaxants. The data shows they add very little, if any, benefit on top of just taking an NSAID. But what they do add is a whole lot of side effects: dizziness, drowsiness, sedation. For most people, and especially for elder adults, the risks simply outweigh the potential benefits.
And that brings us to opioids. On this, the guidelines could not be more clear. Their role is incredibly limited. These are a break glass in case of emergency option, reserved only for patients who have tried and failed everything else. They are absolutely not a first-line or second-line choice. Think of them as a short-term trial, and if the patient isn't actually functioning better, you stop them.
Okay, we're heading into the home stretch with our final section. And this might just be the most important part of our job: creating a real plan for counseling and monitoring. This is where we close the loop and make sure what we're recommending is actually working and that it's safe.
So when we check in with a patient, we have to do better than just asking, "How's the pain?" That's not enough. We need to set actual goals with them from the start. What do they want to be able to do? Is it walking the dog? Playing with their grandkids? We need to focus on function. And a simple 1 to 10 pain scale is a great way to track progress over a few weeks.
And on the flip side, for safety, we need a mental checklist. Especially with those NSAIDs, we need to ask specifically, are you having any stomach upset? For someone with high blood pressure, we should be telling them, hey, check your blood pressure in a week, just to be safe. And for our higher risk patients, we absolutely have to counsel them on what to look for: swelling in the ankles, changes in urination, the classic signs of kidney trouble.
So, there you have it, a whirlwind tour of the new world of low back pain management. We've gone from assessment and red flags all the way to the massive central idea: non-pharm first. So I'll leave you with this one thought to take back to the pharmacy. The next time a patient comes to you with back pain, how are you going to start that conversation differently? How will you make non-pharm first the opening line instead of an afterthought? Thanks so much for joining me for this explainer.